Can you talk a little bit about the difference between detection and diagnosis?
Yeah. So detection is it's more of an early step on the journey of diagnosis. All right. So we don't jump right away from a problem to diagnoses in the healthcare system. You go through what I call the detection phase, detect. So you become detective. So diagnoses is technically you got the right skilled clinician who collected the right information from you, and based on that right information was able to follow certain set of algorithm and said, all right, that's it. Based on the data I have, you meet the criteria for dementia diagnosis. All right. So that's the gold standard. And this is why early on in my conversation, what I recommended the minute you have symptom to go to the gold standard of people who do diagnoses, But unfortunately, a lot of time you don't have that access. We cannot accommodate spending 2-3 hours sometimes collecting data on everybody who have just symptoms. So we try to be a little bit smart. We're trying to, what I call it, segment people with symptoms into the group who have the highest probability of diagnoses. So the detection piece, it's in that area and that zone between you have start symptoms or some loved one discovered that you have a red flags, cool. And then we have this big 2 hours, 3 hours skilled diagnostic assessment that technically gold standard. Not everybody who have symptoms and red flag need that expensive, non-scalable way. There is a way, smart way to, in that journey in the detection that will help you out. So an example I told you with primary care, you try to do what I call a brief cognitive evaluation, less than 5 minutes, that can convert subjective reporting from the patients or the family member into an objective reporting, dominantly memory oriented and executive function oriented. And if that person flag or demonstrate objective problem, and then they're depending on resources available for that clinician who did the brief cognitive battery, they can decide which one need the full comprehensive the diagnostic assessment and which one you don't need the full cognitive diagnostic assessment. So that's in a nutshell the detection piece and the diagnosis piece.
So you talked a little bit about this. I'm going to ask you to be a little bit, I guess, more directed. If someone's going in, what should their provider be using to make a diagnosis? What information do they need? What should they expect it to look like?
Yeah, so let's focus on dementia, all right? So dementia, in order for me to make a diagnosis that you have dementia, I have to prove 2 things. All right, that's the minimum. We can argue how to prove it, but I have to prove you have cognitive deficit, objective cognitive deficit in at least 2 cognitive domains. One of them could be memory, but sometimes you don't need to be memory. So I have to prove that your memory objectively is below what we call 1.5 standard deviation of the mean. All right, but technically, so certain threshold, memory, language or executive functioning or psychomotor speed, attention, visuospatial domain. So I have to prove there is objective cognitive deficit. All right. But that's not enough for dementia diagnoses. I had to prove that this dementia diagnoses actually lead to disability, functional or social disability, that you're not able to live independently at home, or you're not able to meet your basic activity daily living requirement, or your instrumental activity daily requirement, not because of your heart failure and your shortness of breath, not because of your depression, not because of your Parkinson, not because you've been falling a lot, because of your objective cognitive deficit. If I made this connection, and I can say this has been going on for more than 6 months, this is dementia, until proven otherwise. I mean, not even proven. That's dementia syndrome.
One thing that I think that's I'm curious about, I think others might be, is the role that biomarkers can play into detection and diagnosis, and if it's possible to detect changes before a person has some of the symptoms that we've been talking about.
So now we're talking outside of dementia, correct? So dementia is a clinical syndrome,
Mm-hmm.
and you don't need biological marker to diagnose dementia, all right? What the biomarker required is to understand the pathology that caused dementia. All right. And for that one, right now, the most advanced biological markers for the underlying pathology that cause dementia syndrome or underlying pathology that cause cognitive symptoms, even as mild cognitive impairment, that biomarkers are primarily Alzheimer's disease specific. All right. So now we have biomarker to find out if you have the Alzheimer's disease pathology. Okay, and doesn't matter if you have symptoms or not. We're able to tell through access to your spinal fluid, through lumbar puncture, if you have a pathological markers or biomarker for Alzheimer's disease pathology. We can do a brain imaging, expensive obviously, but we can do brain imaging to pick up non-invasive to pick up if you have the Alzheimer's disease pathology. Sometimes even we can look at your MRI and with a special software, we can calculate how much atrophy you have in your hippocampus area, in specific subsegment of hippocampus. That's considered biomarker. And recently, there's been a lot of advancements in blood-based biomarker that can pick up the Alzheimer pathology. All right. Now, other pathology, are going there a little bit, but not as advanced as Alzheimer's disease. So for Alzheimer's disease, we have biomarkers that tell you if you have the pathology, but it doesn't tell you if that it doesn't tell you. You can have that pathology and you have no symptom at all, zero symptoms. You can have that pathology and you have mild cognitive impairment or symptom. You can have that pathology and you have disability like dementia. Cool. Now the question then it become, is there benefit of you find out your biomarker even if you don't have any symptoms at all, not even mild cognitive impairment? Right now, the data does not support that thing at all, because it's not your chance. If you have a biological signature of Alzheimer's disease, your chance of developing mild cognitive impairment and dementia over the next whatever time is not 100%. It's not even 80%. Cool. So it's not just having the pathology is not enough. There's other things, at least require time. All right, so you need time, but also other stuff, because we know a lot of folks, or it could be you have the pathology, you don't have the pathology of Alzheimer's disease, but you may have pathology of something else we can't detect, like the cousins of Alzheimer's disease, and then you will develop dementia even though your Alzheimer's disease biology was negative.
Is there anything on the research horizon that you think you're excited about on that note in terms of detection and diagnosis, that we're getting a better understanding? You mentioned a little bit about the blood markers, but
yeah, I think right now we are moving in the research area for sure, but even I think right now in the clinical area, we are moving from what I call syndromic based diagnoses like the dementia syndrome to actually say Alzheimer's disease. We can now start talking about Alzheimer's disease. All right. And so you can have Alzheimer's disease without symptom. You can have Alzheimer's disease with symptom. Now, who need to know if they have Alzheimer's disease or not? For me personally, outside the research, I need to know if I have Alzheimer's disease, if I have symptoms, whatever that symptoms are, symptoms that are mild, not causing disability, or symptoms that are really advanced, that causing disability. All right. So that's one. For now, we are finally moving to much more precise diagnoses of Alzheimer's disease, not dementia, Alzheimer's disease. And that's, for me, it's very, very exciting, because the precision is much good. And then if we have medication that modify Alzheimer's disease pathology, and we're very, very close for getting the FDA approval for one of these disease modifying agency, then become, now we're moving from syndromic heterogeneous way of diagnosis to a disease specific disease disease. It's almost remind me how we used to say, oh, you just have heart failure. And now we say, no, you actually have coronary artery disease, atherosclerosis, that causing the heart failure through myocardial infarction caused by the stuff, not because of your substance use disorder of crack, or not because you had rheumatic fever, not because you have congenital problem. We know the pathology that caused your heart disease, your myocardial infarction or your chest pain is really atherosclerosis. So we are getting close now, at least in the dementia, to say this is dementia caused by Alzheimer's disease.
Mm-hmm.
You know? And we can do that through the advancement in biological marker for Alzheimer's disease. And also we can do that because if we find out you have Alzheimer's disease, hopefully in the next year or so, I will have a specific disease modifying that pathology.
Dr. Bastani, thank you so much for sitting down with us today to discuss the importance of detection and diagnosis and sharing your expertise. In our next sessions, we will be discussing other components of dementia care. For more information on RTI's expertise in Alzheimer's disease and related dementias, please visit us at rti.org. Thanks so much for your time and thanks for joining us today.
Thank you so much for our opportunity.